We're moving on now, and excuse my voice, it's maybe gone by this evening. We're moving on from the primary spine care in a small clinic or small village, and now we're going on to what would happen in a district hospital for those people who cannot be taken care of in the community hospital, in the community clinics or in the primary spine care clinics. Again, what we're trying to avoid are the silos. We don't want the traditional healer to work by themselves. We don't want the nurse practitioner to work by her or himself. We don't want the chiropractor or the physiotherapist or the family physician to work by themselves. What we want now is, and for the district hospital, to ignore everybody who's on in the other silos. This is what the way it works in many parts of the world, and the way it works sometimes here as well. And in the tertiary hospital is somewhere you just throw your patients that you can't take care of. What we're talking about is those patients who are not able to be taken care of in the primary spine center. This is a graph from earlier. It mostly is people with neurologic findings, some of the infectious diseases and systemic diseases, and perhaps some of the fractures and the acute trauma deformities. So we again have in the model the patients and the people in the center. We have the assessment and the available treatment options that are evidence-based and which can be offered, and that which option you pick depends on the resources and training. And as I say, there may be an occasional group to severe incapacitating pain that becomes chronic, that might benefit from, that may not be able to be handled here. Some of the traumas might be able to be handled, and some of the systemic diseases and infectious diseases might be able to be handled in this setting. Again, reiterating, and I'll be reiterating this every time, most all people can be handled with a public health, or should be access a public health setting. Most people with spinal pain or symptoms can be dealt in the primary spine care center. A few people will now go to the secondary spine care center, and very few, only those who absolutely need it, end up in the teaching hospital or the tertiary spine care center. Reiterating, this is what we want to avoid, is moving all the patients so that a surgeon who has unbelievable skills and years of training doesn't have to spend half of their time taking care of people who do not require surgery. So we're dealing with the second row now, secondary spine care. These should be fed by all the primary spine care. And the example case is Sadia Tawaho, is a laborer who experiences pain on a daily basis. Her pain today is severe and is interfering with her work. She tried aspirin and he tried aspirin and contacted the village healer, who felt better for a little while, but now it is worse. It is a she. She has difficulty walking because she is losing her balance. In addition to back pain, she reports numbness in her feet. So now we have a patient who has back pain, but now has numbness, and she's seeking care. What we're going to ask the next group, this whole session, is to tell us what should be done, or what can be done, and how we should be thinking about the patient who cannot be taken care of in the primary spine care center. Thank you.